To understand how does the abnormal look like, let us see what is the normal. So when you do abdomen circumference, when you do your measurements, you do your biometry, you did your head measurements, now you go into the abdomen. What do you need for fetal size? The baby's head, abdomen, and femur, correct? The Hadlock or other formula will depend on those three. So you have the head, biparietal diameter, head circumference, and then the abdomen circumference and femur length. You need those measurements. When you do your abdomen circumference, there's certain landmarks that you will see. You have to see a stomach bubble, or the stomach itself. You have to see the umbilical vein coming into the abdomen here, and you see left portal vein here. Okay. So if you don't see this stomach, then what's going on? What is the possibilities? Give me 3 possibilities. Atresia of what? Esophageal atresia. So the fluid is not connecting from the esophagus to the stomach. Very good. And the word atresia means that non-canalization, that the esophagus actually develop as a solid organs and then it canalize, become hollow, the same with the intestine. So if that doesn't happen, then there is no connection between whatever is happening in the esophagus and above the esophagus with the stomach, so the stomach will not show up. Well, in this case, the baby cannot swallow. The fluid around the baby will increase. You will have polyhydramnios. Very good. Number 2. I wanted you to think. Exactly. The stomach can be empty. Maybe the baby is not swallowing. Okay, that can happen. Well, it happens sometimes by itself or neuromuscular disorder, like muscular dystrophies. Sometimes the stomach doesn't fill because the baby is not swallowing, or some CNS abnormalities. Okay, that's a good possibility. What's the third one? Think. The stomach is there, but it's not in its normal position. The stomach is in the chest, for example. So you're not going to see it here, right? So if you don't see a stomach where you should see it, then think about, is it in the chest? Is it empty? Or is it not filling? Okay, so this is what's going on here. This is the baby's chest. You see the heart here. Here's the fourth chamber. This is the aorta. And this is the stomach right next to the heart. The stomach should never be right next to the heart in a fourth chamber view. So this means that this stomach is in the chest, correct? What do you think about the fluid here? Looks like a little bit abundant, like increased, yeah. In this view, okay, so here we see the heart here. Is that heart axis looks normal? It should really be here in the middle there. This should like push to one side, correct? And this is really the right side of the heart, because here is the spine, so this is the left side of the heart, this is the right side, but looks like the whole heart moved to the right a little bit. And does this here, this echogenicity, look like this or different? This is nice and smooth and homogeneous. This is heterogeneous. So what is this here in the chest? Bowel. So we know the diagnosis of diaphragmatic hernia now is, what I don't have here, I should got you a longitudinal view, and then you see the diaphragm, and that's one of the essential views that you should get. A sagittal view of the baby's abdomen and chest together. You see the diaphragm, you see the stomach under the diaphragm. If you don't see it under the diaphragm and you see a sonolucent area above the diaphragm, then it's either a stomach, that would be diaphragmatic hernia, or it could be what we said before, type 1 CCAM. That's the most common tooth cyst in the chest, okay? Now, somebody asked me about the heart. Actually, the heart is a totally different topic, but I'm going to mention a few things about the heart. So, heart condition is one of the most common congenital malformation. It happened about 0.8%, or roughly about 1%. So 1% of all newborn babies might have some congenital heart. What you need to know about the heart is you look for the heart for 3 main things: the size of the heart, the situs of the heart and the axis of the heart. What does the size mean? Just look at the chest and see the relative size of the heart to the chest. And the heart usually about 1/3 of the chest. If the heart is more than 1/3 of the chest, then you either have a narrow chest, a normal heart, or you have a small heart and normal chest. What's the difference? A small heart and a normal chest indicates congenital heart problem. A normal heart and a small chest, that can be skeletal dysplasia, and that also lead to a very small lung volume and most likely will be lethal skeletal dysplasia. The situs means that the heart is on the left side of the body together with the stomach on the left side, and if the heart is on the right side, then you have situs inversus. Sometimes you have stomach and the heart on the right side of the body. What about the axis? The axis, you're going to drive a anteroposterior line, and then the axis of the heart is going to be to the left of that by about 45 degrees. Remember, 45 plus 15 or minus 15. So anything 45 plus or minus 15 is normal. 45 minus 15 is what? 30. And then from 30 to 45 and 15 would be 60, right? 30 to 60 degrees, that's considered to be normal. Less than that is abnormal, more than that is abnormal. So that's about the heart. Let's go back now into the fetal abdomen. We're going to discuss abdominal wall. And the abdominal wall is basically either gastroschisis or omphalocele. Well, let me look at this. I divide the fetal abdomen abnormalities into three different things. There is defect involving the umbilical area, so like the middle of the abdomen, that would be gastroschisis or omphalocele. Defect involving the lower abdomen, that would be bladder exotrophy. This means that the bladder wall did not separate from the abdominal wall. The bladder actually empty, is totally open into the amniotic cavity, because instead of having a bladder wall and then abdominal wall, they will be fused together and the bladder will be open to the amniotic fluid. So that's what bladder exotrophy is. It's extremely rare. And then you have a defect where the whole abdominal wall is gone. You don't have lower abdominal wall, you don't have upper abdominal wall, or even middle, abdomen. And that means that the baby will be, no abdomen, the baby will be attached to the placenta with just a cord. Cord, usually very, very short cord, because the baby cannot move anywhere. And that's a severe form of abdominal wall defect and 100% lethal. And that's called body-Stoke anomaly. So body-Stoke anomaly is rare. Bladder exotrophy is rare. The two common ones will involve the umbilical and para-umbilical region. So it's the umbilicus and to the right of the umbilicus. That would be gastroschisis or omphalocele. And remind you that we said there is 4 basic features for each one. I like to make things symbolic, like the 4. This defect here, the diagram showed that there is some bowel to the right side of the umbilical cord insertion, right? There is no covering membrane, and the lesion is para-umbilical, not umbilical, is next to the umbilical cord insertion. That's why the cord insertion is normal. So there is already here 3 features. 1 is the cord insertion is normal. 2 is the defect is para-umbilical, to the right of the umbilicus. And 3 is there is no covering membrane. Okay? How does this bowel look like here? This is floating bowel within the amniotic cavity. That's what we call cauliflower appearance. Loops of bowel floating together within the amniotic cavity. This is the view that I like to get, because in this view, I put the color and I see the cord insertion look normal. So the cord insert normally into the abdomen. There is a lesion next to the cord insertion, and there is no covering membrane. Three features: normal cord insertion, no covering membrane, and the lesion is paraumbilical. Okay, now the fourth one that I will tell you here is you will never get herniation of the liver into this defect. So it doesn't happen. Even the textbooks say rarely happen. No. Anytime we see liver herniation through abdominal wall defect, we have to make, all effort to label this as omphalocele. Not because you can have an omphalocele and then the sac rupture. Now you have a defect that's not covered by a sac with the liver inside it. Well, that would be omphalocele, still omphalocele. So remember the four features: normal cord insertion, the lesion is paraumbilical, no covering membrane, no liver herniation. Add one more: with gastroschisis, no increased risk of fetal aneuploidy. So now you have 5. It's mostly sporadic. It's believed to be caused by vascular event, or somehow the omphallomesenteric artery is ruptured. So it doesn't supply this area of the abdomen, and therefore that area will not close, will have a defect, and then the bowel will herniate through that defect. These are the 5 features we mentioned already. All right, omphalocele. So everything we said about gastroschisis, we'll say the opposite of it with the omphalocele, which means that instead of the cord inserting normally into the abdomen, no, the cord is abnormally inserted into the defect, actually inserted into a membrane. So the lesion is, instead of being paraumbilical, the lesion is umbilical. It's right in the umbilical area. The gastroschisis is not covered by membrane. Omphalocele is covered by membrane. Gastroschisis, the liver does not herniate into the defect. Omphalocele, the liver herniate into the defect. Gastroschisis have no increased risk with fetal aneuploidy. Omphalocele have about 30 to 40% risk of fetal aneuploidy. 5 against 5. Any questions? No? Easy to remember? What about the pathogenesis here? Why omphalocele happens? That's interesting. Now, we said that we think that the pathogenesis of gastroschisis is vascular event or omphallomesenteric artery occlusion or rupture. Okay. The omphalocele is a different story. During the abdomen development and early embryonic life, 3-4 weeks of embryonic life, the bowel develops outside the abdomen. And then the bowel goes inside the abdomen, and then the abdomen closes as a zipper from up and from down toward the umbilical area. So if that closure did not happen correctly, you will still have the abdomen out, which is the omphalocele. And why the bowel developed outside the abdomen early in embryonic life, we don't know, but the theory is because of the size of the liver and the kidney growing, the bowel does not have enough room, so they develop outside. 3 to 4 weeks, that development is done by about 8 or 9 weeks. So by 8 or 9 weeks, the bowel goes back. That's called, if you see it at 8 weeks, you see some of the bowel outside. It's called exomphalus or exomphalus, and that's normal up to 10, 11 weeks. If I see it after 12 weeks or more, then we have, abdominal wall defect. And Jane said the bowel rotate. It rotates 90 degrees first, and then it will go inside and then rotate another 180 degrees and then stay in its normal position forever after that. Okay, if there is malrotation, then it happened very early in life. Okay. So that's how it looks like. Usually you have a covering membrane, you have bowel, and you have a liver within the sac, and it depends the size of the lesion here. It's one of our babies. This is the abdomen here, here's the stomach, and this is the liver, and you have a covering membrane and cord insert here. A cord insert into a defect where the liver is coming out, and there's some bowel under that. It's another baby here with bowel herniation and the liver herniated into the sac. And another one. Here's the liver, bowel, cord insert into it. This is one of our babies here, and see how big that lesion is. That baby had normal karyotype, have surgery after delivery. If that defect is so big, they don't close it initially. They put silo around the defect and they keep it until the baby gets bigger, so you have more skin, and then you can close that later on. And actually very, very successful surgery. If there is no other abnormalities, no chromosome abnormalities, the outcome is good. All right, so the features of the omphalocele. So again, the pathology of the omphalocele is the failure of the gut to re-enter the abdomen by about 10, 11 weeks. It starts like 3 or 4 weeks, but it finished 10, 11 weeks. And then the diagnosis is the 5 features we said. The defect is umbilical, the cord inserted into the defect, there is covering membrane, the liver might be herniated, and there is increased risk of fetal aneuploidy. Okay, Beckwith-Wiedemann syndrome is a certain type of omphalocele. So in this case, this baby is very huge, have macrosomia and macroglossa, and umbilical defect, which is omphalocele. That's called Beckwith-Wiedemann syndrome. What is the importance of this? Some of these cases might have paternal disomy. So part of the short arm of chromosome 11 might be coming both copies from the dad rather than one copy from mom, one copy from dad. Recurrent risk is about 25%. Body stalk anomaly, remember we said gastroschisis and omphalocele involve the umbilical and periumbilical area. The body stalk anomaly, the whole abdominal wall is gone, so you're not going to see really any abdominal wall. You're going to see the baby attached with a very short cord to the placenta, and it's 100% lethal. That's how it looked like here. So everything is hanging outside the abdomen, including the liver, the kidneys, the bowel, everything out. So we finished with the abdominal wall. Okay, when we talk about the abdomen, there is abdominal wall and abdominal organs. And the organs inside will be either bowel, esophagus, duodenum is part of the bowel, or kidneys and genitourinary tract. Let's talk about atresia first. We defined what atresia means, which means non-canalization. These organs develop as a solid organ, and then they canalize after that, become hollow organs. Esophageal atresia. We need to differentiate between esophageal and duodenal atresia. That's important. Bowel atresia is easy. And colonic atresia is rare. Let's go to esophageal atresia. So the esophagus here did not canalize. One part of it here is still solid. It will look like actually 2 disconnected areas here, proximal part and distal part. And usually the distal part is connected to the trachea. This is about 90% of the time. This is about 10% of the time. The difference between here and here is this proximal part here did not connect to the trachea. So whatever the baby actually feeds, it will come back without going into the lungs. The difference here is this part here is connected to the trachea. So if that is not diagnosed and the baby delivers and they started feeding the baby, all of this feeding is going to go to the lung. The baby will choke. The sonographic feature of esophageal atresia is, where is the stomach bubble? If this part of the esophagus does not connect to the stomach, which should be under the esophagus, then the stomach will not be filled. So the sonographer writes in the report, absent fetal stomach. Well, it's not absent, it is there, it's just not full. Okay, so I said non-visualized, not absent. Non-visualized fetal stomach. Absent means it never developed. Okay. So your 2 main features here, you don't see the stomach where it should be, and your amniotic fluid is increased because that fluid baby cannot swallow. It will go back to the amniotic cavity. And there is high association with TF fistula. Esophageal atresia can happen either isolated or part of a syndrome, or can be associated with other malformation, okay? And can be associated with trisomies, especially trisomy 21 and trisomy 18. This is one of our cases here, but look at, I put this here because to see the fluid, too much fluid, and then here you can see, I don't see the stomach, and you see too much fluid, then that's esophageal atresia. Okay, so in esophageal atresia, you're not going to see stomach bubble. I like to do things in comparison. Compared to that, duodenal atresia, you're going to see two stomach bubbles. So one of them, you're not going to see any stomach bubble. The other one, you see two stomach bubbles. The duodenal atresia. Why do we see two stomach bubbles? Well, let us see what happened. This is the stomach. This is the esophagus. So the esophagus is open to the stomach, and the stomach is filling, okay? And this is the end of the stomach here. This is the first part of the duodenum, and this is the second part. And the second part is atretic. The second part is where the problem is. So then the first part will fill with fluid, and you will have two fluid-filled adjacent, cavities. One is the stomach, and one is the first part of the duodenum. That's why you end with a double bubble. So duodenal atresia, the characteristic feature, double bubble sign, or two connecting adjacent fluid-filled structures. You might not be able to diagnose that early. Like if you look at 14, 15 week, it might not show until 18 week, or even at 24 weeks. Polyhydramnios is common also because you have the second part of the duodenum is atretic, so everything proximal to that can be dilated, and then the fluid can go back to the amniotic cavity. And there is very high association with trisomy 21. How high is that? Is when we see double bubble sign, we'll say about 30% risk that the baby will have Down syndrome. Okay, if it is an isolated atresia, duodenal atresia, and the chromosomes are normal, everything, all the other structure is normal, the outcome is excellent. Okay, genitourinary malformations. The kidneys is probably the most variable organ that we see on the different embryology of the fetus. Because you can have two normal kidneys, you can have one kidney present, one kidney absent or atretic. You can have one normal kidney, one pelvic kidney. You can have kidney missing in one side and the other side have duplicated kidneys or two kidneys. Or you can have both kidneys connecting together but very low down behind the bladder. Remind you that the kidney developed initially as a pelvic organ. So the kidney develop in the pelvis and move up into the upper abdomen later on, move to the abdomen. So sometimes that ascent did not happen. So it is common to see a pelvic kidney, or the two pelvic kidneys would be horseshoe kidney, like this one here. The most common thing we see in the kidney is pylectasis or hydronephrosis. So mild dilatation of the epidiameter of the renal pelvis is called pylectasis. If we have major dilatation with the major connecting canaliculi here are dilated, calyces, that would be hydronephrosis, usually 10 millimeter. We measure the kidney in its epidiameter, anteroposterior diameter. So here is the spine, and one kidney here and one kidney here, and we measure anteroposterior diameter. Actually, it should be here. You can get a parasagittal view, and in this here, you still can see the kidneys are dilated. When we see dilatation in the kidney, then we go ask ourselves, why is this kidney dilated? The most common reason for it is reflux. So you have urine running up to the kidney from the ureter instead of running from the kidney down the ureter, down to the bladder. So reflux is common. It also can disappears. So later on, you can look back at the kidney, and the kidney looks normal. So see mild dilatation, pylectasis, we bring the patient back about 5 to 6 weeks. If it's still there, we bring her back one more. But if we see it and 5, 6 weeks it look normal, then we reassure her we don't need to rescan the baby. Everything is fine. If it is not reflux, what else can happen? It can be narrowing between the renal pelvis and the ureter. So that's called UPJ obstruction. That's the most common narrowing. UVJ obstruction is narrowing between the ureter and the bladder. Well, in this case, with UVJ obstruction, if the narrowing is down close to the bladder, then the ureter will be dilated, and you're going to see the ureter dilated then. So reflux is the most common, followed by UPJ obstruction, followed by UVJ obstruction. The prognosis, of course, depend on the severity, but most of these have very, very good prognosis, the mild cases, and depend on whether unilateral or bilateral. There are some cases that started as a very mild pylectasis, and now we're seeing huge dilatation of the kidney. One of them I wanted to add the image. Just the patient came yesterday, they didn't have the time. The kidney is so huge that you can hardly see any renal cortex. So the function in that kidney is gone. And the patient is asking, what can we do? Well, what can we do is, as long as the amniotic fluid looks normal around the baby, you don't do anything, okay? You wait until the baby delivers, but we refer her to pediatric urology. They will counsel her. They will see the baby after delivery. After delivery, they evaluate, is that kidney has some function, reasonable function, or no function. Now, if the fluid around the baby started to decrease to the extent of oligohydramnios because of the size of that kidney, I can drain that kidney. I can put a shunt in it. Like that's what we do with the bladder. You can put a pigtail catheter and you drain the kidney and you leave the catheter there until they deliver. But most of the time the baby will pull it out. And that will drain the obstruction to the amniotic fluid because you actually put the shunt from the kidney, you leave it hanging from the baby's skin into the amniotic cavity, and that will drain the fluid there. Sometimes you can just go with the needle, aspirate that kidney, and it might not happen again. But we try not to intervene as long as the amniotic fluid look normal. Right. Now you have one kidney normal, and this is a duplication. If you have duplication, this means that you have two ureters. How you diagnose that? You look into the bladder and you find like a little cystic area in the bladder called ureterocele. Benign. We don't have to do anything before the baby delivers. After delivery, they evaluate because that ureter usually ends with recurrent infection and pyelonephritis, so they might need to take that ureter out and they leave that part of the kidney here. Okay. This is early in pregnancy, and we hear 15 weeks and 5 days. And this is the lower abdomen. What is this here? You see that? That's fetal bladder. So when we see that, then the obstruction is actually very distal, so which will be the urethra. So the urethra is not draining out to the amniotic cavity, then all the fluid will be collecting into the bladder. And then if you leave that, keep going with the pregnancy, then the urine will move up, and then you will have hydroureter and then severe hydronephrosis. So this is when we see that, we want to rule out bladder outlet obstruction or posterior urethral valve. This is now called lower urinary tract obstruction. Lower because it is the urethra. As I said, if you leave that going, then the bladder can become so huge that it will stretch the skin around it and will cause the Broom belly syndrome. Now, the bladder outlet obstruction or posterior urethral valve only happen in male fetuses. So if you see that in a female fetus, then it's what we call a primary Broom belly rather than secondary due to urethral obstruction. This is just a catheter. You can put that catheter in the bladder and you can drain it. When you look carefully into the urethra here is the bladder, you can see the proximal urethra is dilated, and that's called keyhole appearance. That's characteristic for a urethral obstruction called keyhole because the distal urethra is closed completely, the proximal urethra will be dilated. And this is a catheter here inside the bladder draining it out. Usually the bladder wall will become thick because it will try to overcome the obstruction and then kind of give up after that. So posterior urethral valve happen in male fetuses, severely dilated bladder, severely dilated also ureter, and you see the keyhole appearance, and then eventually will lead to destruction of the kidney, and the kidney will have no function in it. There is a type of a primary prune belly syndrome that can happen also in female. That's because the smooth muscle itself of the bladder is just very, very weak. So the bladder never contract and will keep dilating. It will leave the same effect. Okay. So that's what happened with the drainage system. What happened to the kidney itself? You can have renal agenesis. You can have one kidney did not develop or both kidneys did not develop. If you have bilateral renal agenesis, both kidneys did not develop, that's lethal because you need urine, fetal urine, to go to the amniotic fluid to have the lung develop. Amniotic fluid depend mostly on fetal urine, and then there is substances in the fetal urine that actually promote lung maturation. So if you have no fetal urine coming to the amniotic fluid, because we've done sometimes that there is no fluid around the baby, you go and you put normal saline and you can keep going back every week or every 2 weeks, put normal saline and you deliver those babies at full term. No lung maturation. Those lungs are so stiff, they will intubate the baby, they will try to just put some air in those lungs, it doesn't move at all. So we know that fetal urine is essential for lung maturation. So a unilateral renal agenesis, okay. All what need, the baby need one kidney or even half a kidney to function normally. But if you have bilateral, then it will become fatal. So bilateral agenesis, the problem when we see with bilateral renal agenesis, if we see somebody coming during third trimester. So I'm on call and I got a phone call from my OB doctor on call. It's like, I need you to come and just help me scanning this baby here. So we transferred the patient at 33, 34 weeks from another hospital because variable decelerations, okay? Fetal heart deceleration and no amniotic fluid. So quote unquote, rule out rupture membrane. So she comes in, you scan her, there is no fluid, no amniotic fluid. So the first thing you look at, okay, did you have any leakage? I'm not sure, I feel wet sometimes, but did you have gushes of water coming out? No, I don't. So that's probably did not rupture membrane. Then you look at the abdomen. You look at the kidneys. Do we see normal kidneys or not? If I see normal kidney, because you should see renal pelvis at least 3 millimeters or so if she's ruptured membrane and the kidneys are normal. But we don't see, we don't see kidneys at all. Now, there is a little mistake here. When the kidneys are absent, what's above the kidney? Adrenal gland. The adrenal gland will hypertrophy, will fill in the space. So sometimes they scan and they think they have seen a kidney. They have seen something in there, but it's really not a kidney because it doesn't have the kidney shape, doesn't have a renal pelvis. So the best thing I do is I put the color on. So when you put the color there and you don't have any renal arteries coming out, you don't have kidneys. So this case is 100% lethal. We don't need to do a cesarean section for the baby. Baby's not going to make it anyhow, and the baby doesn't need to stay in the hospital. So just follow up week by week and make sure that the heart rate is still there, and when she goes in labor, you deliver. It's sad, but you need to diagnose that very early in pregnancy because it's lethal. So any lethal condition, you want to diagnose it very early, before 24 weeks. So Potter syndrome is called also Potter sequence. If there is no fluid around the baby, what will happen? Everything is smushed and pushed. So you have retracted, jaw, the skin behind, the ears will be pointing it backward. The face will be pushed in. The skin will be contracted. The extremities don't move, so it will be flexed position. But the most important will be lung hypoplasia. The lung will never develop because we said the lungs need fetal urine to develop. So this was agenesis, bilateral agenesis. We moved into something different, multicystic dysplastic kidneys. What I want you to know is to differentiate between polycystic kidney and multicystic kidney. I like to put that word dysplastic because the multicystic is always dysplastic. So there is polycystic kidney and there is multicystic dysplastic kidney, or you can write MCDK, multicystic dysplastic kidney. That's the way I like to write it. And the way it looks here, this is a pathology specimen, multiple cysts, different size, no reniform appearance, so the kidney shape appearance is gone. The kidney doesn't even look like a kidney. No renal pelvis, okay, and that's the pathology. Let's see the ultrasound features. Large cyst, small cyst, no renal pelvis. Here, this is typical one here. So you can see multiple cysts, no renal pelvis, and the kidney doesn't have its shape anymore. The kidney can be large or small, it doesn't matter. So these cysts that form are nephrons that's disconnected from the collecting system. So the urine cannot go anywhere. It will stay within the cyst and enlarge and just stay there because the nephrons are not connecting to the collecting tubules and calyces. If you have one kidney that's affected, the other kidney is normal, that kidney needs to be removed after delivery because these babies will end with hypertension due to the kidney disease and may develop hematuria and malignancy. If the kidneys are bilaterally involved, so if the kidney doesn't function at all, even if there is ureter and there is bladder, are we going to see the bladder? No, it's not filling. We're not going to see a ureter either or a bladder. So a bilateral multicystic dysplastic kidney will look like Potter syndrome eventually because no urine will come out and no amniotic fluid. Again, 100% lethal. Is one syndrome called Meckel-Gruper syndrome. I think we mentioned that this morning. It's a polydactyly, encephalocele, and bilateral multicystic dysplastic kidney. 100% lethal, associated with trisomies, mostly trisomy 13. It can be autosomal recessive, so there is high recurrence risk, and it's important to counsel the patient. Now, that was the multicystic dysplastic kidney. Now, polycystic kidney. The polycystic kidneys, forget about here, the slides say infantile. There is 4 different types. There is fetal type, newborn type, infantile, and adult. So 4 stages. Well, actually, it's the same disease, not exactly the same, but it depends on when do we diagnose it. So if we diagnose it in utero, that's fetal. After the baby is born, newborn. As a child, infantile. Adult is adult polycystic kidney. Now it's important to differentiate between fetal, when we diagnose it, and adult. Adult polycystic kidney, is it autosomal dominant or autosomal recessive? And then the fetal is opposite. Okay, it's easy. Adult, A-D, autosomal dominant. That's how I remember it. Just, adult, A-D-U-L. So adult, autosomal dominant. The fetal is opposite, it's autosomal recessive. So those kidneys are, we said this, multiple cysts, numerous, thousands of them, but they're all small, 1 to 2 millimeter cysts. So how is the kidney going to look like? Echogenic, white, and also large. So large echogenic kidney is polycystic kidney. This is just filling here. The kidneys usually fill the abdominal cavity, leaving very small space to the other structures. This is our baby here. So this is all kidneys, like filling the abdomen. Here again, this here and here. Now you appreciate how wide those kidneys are. See that? They're almost as wide as the vertebrae here. In this case, actually, you can see a renal pelvis, not like the multicystic dysplastic kidney. because initially you will have, this baby is one of our babies that we kept following up, and initially there was normal amniotic fluid. Toward the end of the pregnancy, there was severe oligohydramnios, and the kidney got much bigger and more echogenic. So we said the adult is autosomal dominant. This one here is autosomal recessive with risk of recurrence 25%. The earlier you diagnose it, the more severe the lesion is. So it becomes like, the perinatal type, it's in the fetus or newborn, is usually fatal. The adult is not, because they chose up later in life, adult life. So we've done now with the fetal brain, fetal neck, chest, and the abdomen. We're going to go to extremities. So I added this in the last couple of times here because I think it's important when you do a scan to look at the humerus and the femur and hands and feet. We don't look at radius and ulna unless I tell you when, or the tibia fibula. Why do you look at the femur? Because the femur, you have to get the measurements anyhow for estimated fetal weight. You're going to get the estimated fetal weight by head measurements, abdomen, and the femur, so you look at the femur. What if the femur is 3 weeks off? Now, you have an 18-week fetus, then you're scanning, and the femur is only measuring 15 or 14 week. What you do? What kind of thinking goes in your head at that time? Well, I might have a baby with Down syndrome. Maybe the dates are not correct. Or I might have some other skeletal abnormalities. So if the dates are not correct, your head measurements and abdomen measurements will be matching the femur. But if they are matching 18 week and the femur is 14, 15 week, then more likely I have a baby with Down syndrome or I have a skeletal abnormality here. So if the femur is short, then I go and measure the humerus, and I look at the tibia, fibula, radius, and ulna. You measure all the bones. If all the bones are short, you have a skeletal dysplasia. So the humerus and the femur is the proximal bone, okay? And if those are shorter than normal, for the proximal bones, that's called rhizomelia, okay? That's the proximal, long bones are short. If the middle bones are short, that would be radius ulna, tibia fibula. Because it's middle, it's called mesomelia. If the hands of the babies and the feet are extremely small, that's called acromelia. If everything is small, then it's micromelia. So if you have everything is small, it's micromelia. So this is just a classification. Now, the fetal extremities, there is so many diseases that can affect the fetal skeleton that I'm not going to go into details, but I will just mention a few of them. If you suspect short bones or skeletal dysplasia, you really have to look at the fetal skull very carefully, because in many cases, skeletal dysplasia, the skull will be either extremely thin or it will look abnormal. You look at the thorax, make sure that there is no broken ribs. If you can look at the scapula and the spine. Some of the skeletal dysplasia are lethal, like thanatophoric dysplasia. I'll show an image. Type 2 osteogenesis imperfecta. Hypophosphatasia. You can see that if the skull bones are very, very thin, and your landmark will be, you can see the intracranial anatomy very clear. Like all of a sudden you see sulci, gyri, all the anatomy inside the head, very, very clear. And that's because the skull bones are very thin and very less calcified because of the hypophosphatasia. Achondrogenesis, another lethal one, and achondroplasia. This is the fetal arm we're looking at here. So you see the arm here, but then the bone is, see, short and bowed. That's abnormal. Here's the leg. Here you see that, the bones of the leg and, have club feet, and the bones are abnormal here. Here's this fracture. You can see here's the femur there, bowed and fracture. And that's 20 weeks, okay? Guess what this baby had? Just a guess. Osteogenesis imperfecta type 2. Okay. Now that's another, when you see very short extremities, very large head, and high drops, that's thanatophoric dysplasia. They call the femur the phone receiver appearance because kind of the shortened, but that's the old phones, like the 1950s phone. So that's how it looked like, thanatophoric dysplasia. Now, we look at the hands and feet just for two things. One, make sure that the hands open and close, and then make sure that you see the middle phalanx of the fifth bone, because that absent middle phalanx can be a feature of Down syndrome. The feet is important to look, make sure that we don't have a club feet or rocker bottom feet. Now, sometimes the baby will hold that foot in a kind of funny position that will look like a club, and if you extended your exam, it's going to look normal, so we're okay with that. You can see here the hands are clenched, but if you, as I said, that 3D becomes not very easy now to diagnose like club feet and rocker bottom feet and clenched hand. You just get your image and put the 3D in there. Here you see, you can hardly see it, but this is kind of overlapping the thumb and the fifth finger over 2 and 3 and 4. That's an important position. If the baby stayed in that position, that's a trisomy 18. Now, trisomy 13 is extra digit, polydactyly. Trisomy 18 is usually that fixed thumb and fifth finger over 2, 3, and 4. Like that. We mentioned that before. It's polydactyly here, trisomy 13. Now, clinodactyly means just the digit is kind of bowed, not straight, or absent middle phalanx of the fifth finger. That can be a sign for Down syndrome. This is club feet here. Rocker bottom feet here, you can see the foot will look like it's bowed up, and in the back here will stick behind the leg bones and kind of curve up. That's the rocker bottom feet. A sandal gap, kind of really it's not very common. You look at, there is a big gap here between the big toe and the second toe. This is not an anomaly, this is just a baby saying, leave me alone, I'm good. When we look at certain sonographic marker, we can pretty much figure out, do we have here trisomy 21, 18, or 13? These are the common ones that we need to sort them out. This is a picture of Kodachrome for the OBGYN doctor that's going to go for the exam. They'll show you. But that's how the chromosome first look like, and then they line them up and they number them. And if you notice, number 1 is the longest chromosome, and then number 22 is the shortest chromosome. So they really line them up by the size of the chromosome. And then, of course, there are certain areas within the chromosome they look at to make sure that they got the right chromosome. But 46 chromosomes in a normal baby, either XX or XY. And if we throw in fluorescent dye on certain chromosomes, like 21, 18, 13, and we see 2 signals, then we're okay. If we see a third signal of any color, then we have trisomy of that chromosome. That's how we get fish within 48 hours. We can have a result on chromosome 21, 18, or 13, because we don't wait until the final culture. They can just put in the fluorescent dye, and they tell us within 48 hours, do we have trisomy of 18, 13, 21 or not? And they also do it for X and Y. Here, abnormal signal here, see, it's trisomy. Here is we have an extra chromosome number 16, so that's trisomy 16. Those babies don't make it to the second trimester. They end with usually first trimester miscarriage. That's the most common reason for first trimester spontaneous miscarriage chromosomal abnormalities. If we have an extra chromosome 21, then we'll have 3 of the chromosome 21. So we got our sonographic feature for trisomy 21 from how these babies, they look like in real life. And what you see here is a flat nasal bridge or absent nasal bone, so absent or very small nasal bone, Okay, the tongue throbbing is another feature. The ears is low ears and malrotated. That doesn't show you the skin, but usually the skin behind the neck is thick also. So in this baby here, we see a low ear, very hypoplastic nasal bone, absent nasal bone here, thick nuchal fold, very small nasal bone. See the tongue throbbing coming out there? That's the baby with Down syndrome. Now, if you look at the hand, 1, 2, 3, 1, 2, 3, only 2 here. So absent middle phalanx of the fifth finger can be another bilateral pylectasis. It can be marker. We said it may be isolated finding or it can be a marker for Down syndrome. But the kid that we're looking at have other features. So these are the kidneys. And there was a study called the Radius studies back in the mid-90s that showed that bilateral fetal pylectasis can have 3% association with Down syndrome. We don't think it is that high if it is an isolated, but that's what the study showed. So if somebody comes with dilated kidneys, what's the chances that my baby has Down syndrome? I haven't done a blood workup for Down syndrome. There is nothing else wrong with the baby. I'll say 3% or less. To the opposite of that, if you have duodenal atresia or cardiac defect, then 30% chance that the baby have Down syndrome. It's the same baby, but we have heart defect. We have what we call AV canal malformation here. See, the septum here is not going all the way down to the valve, so you have this big chunk of tissues missing. Intracardiac echogenic focus. Here's AV canal again. Double bubble sign. We're going to move to trisomy 18. That's also called Edwards syndrome. That's the one with the thumb and the fifth finger overlapping, 2, 3, 4. And that's usually associated with major sonographic finding like microcephaly, ventriculomegaly, abnormal extremities, severe IUGR. And the head usually looks like a strawberry looking head. Okay, so because it's wide here, the cephalic index will be high. Biparietal diameter over the occipitofrontal diameter will be high. And also it's common to see heart defect and choroid plexus cyst with trisomy 18. See this head here? Looks like strawberry. It can be associated with omphalocele. Right, trisomy 13, that's the one that I call it, that's the chromosomal abnormalities of the midline. Why it is midline? Because trisomy 13 is the one associated with cleft lip, cleft palate, abnormal eyes, or even cyclops, and also holoprosencephaly. So it's kind of really, I call it the syndrome of the midline. So if you see holoprosencephaly, cleft lip, cleft palate, abnormal eyes, hypotelorism, or cyclops, then it's trisomy 13 until proven otherwise. Holoprosencephaly, okay? That's the baby trisomy 13. And what is that? Proboscis. You have a little protrusion there. There is no nose, no nostril. That's just some soft tissues just sticking above the eye. And there is really no eye sockets that you can see here. This is usually in a larger baby to look like that. Usually associated also with abnormal hands and feet, like club feet and rocker bottom feet, and postaxial polydactyly. And that's the one that can be associated with multicystic dysplastic kidney, severe IUGR. We finished with trisomy 18, trisomy 21, trisomy 13. Now, trisomies are associated with advanced maternal age. So the higher the maternal age is, the higher the risk for trisomy. Mother comes and she's 42, then she's at risk for Down syndrome, and also the other trisomies, trisomy 18 and 13. To the opposite, a missing X chromosome, that's 45X, we don't call it XO, we call it 45X or Turner syndrome, is not associated with advanced maternal age. So advanced maternal age is not a risk for Turner syndrome. But Turner syndrome can present with the largest cystic hygroma that you can see sometimes, and sometimes can be subtle, very subtle, like just thick nuchal fold. there is increased risk for coarctation of the aorta and horseshoe kidney and IUGR. A different chromosome problem here called triploidy. That's when you have an extra copy of each chromosome. So the trisomy is for one chromosome, but triploidy is an extra copy of each chromosome. So we have the total number of 69 chromosomes instead of 46 chromosomes. Usually they will present as thick placenta, oligohydramnios, and the placenta might look like molar appearance, have a multiple small cysts in it, like that, or like this. And ventriculomegaly can happen. And if you do the beta HCG, will be over like 500,000, usually close to 1 million, and might be associated with partial molar pregnancy. The ovaries will be overstimulated, hyperstimulated ovaries because of the beta HCG is very high. At the end, what we'd like to do with looking at the baby's structures and everything is to have a very healthy, happy baby.